This is an EEG of a 32-year-old woman with a possible seizure. So starting out, again, this is our double banana montage. This is the entire left hemisphere, temporal, parasagittal. This is the midline and right parasagittal temporal. I don't like this montage because, as I've stated before, I like to directly compare the left and right hemispheres because I think it's easier to catch subtle asymmetries when you're able to directly compare each side. All right, now this EEG I wanted to show because I wanted to um, to emphasize that there is a wide variety of normal backgrounds. Not everyone's background looks really well formed and really pretty, and so it's good to be able to identify what's normal and what's abnormal. Now here we have the posterior dominant rhythm, the patient's eyes closed, and we can see this activity. It's about 9 to 10 hertz. And looking at the hemispheres here, we've got activity that does look symmetric in terms of amplitude and frequency. And if we want to measure the amplitudes, we've got about 75 microvolts there. So it's probably about 30 to 70, 30 to 80. And again, it is symmetric. And in terms of the organization, we've got a nice frequency amplitude gradient. We can see this faster activity in the anterior head regions. It's lower amplitude, and as we go back, the amplitudes increase, the frequency decreases, and that's a nice, beautifully organized background. And the last thing we want to look for is reactivity of the background, and that means change when the eyes open and close. Now here we see a little bit of a change. This is not from eye opening or closure, but the background, we lose that nice background activity here, and we lose the frequency amplitude gradient. This is drowsiness, so the patient is momentarily drowsy here. The patient's also hyperventilating, which we can't really tell just from looking at the EEG because there's no change. And interestingly here, the tech wrote that the patient was asleep, but we know that's not true because here's the awake background. And here's drowsiness again. And I know that because we lose the nice frequency amplitude gradient and the background is somewhat more attenuated. We do sort of see a little bit of background here. This is a better illustration of drowsiness here because we see complete attenuation and it just looks very, flat, kind of diffuse theta activity. Here the patient wakes up and we go ahead and continue on. Now the reason I wanted to show this is because sometimes her background does look a little bit spiky, and it's important to realize that some people do have backgrounds that do look a little spiky like this. And oftentimes this will happen when patients are on certain medications such as benzos or narcotics that can make the background look spiky. And sometimes you need to be able to discern that spikiness from true epileptiform activity. Now something different is happening here. If you noticed, I'm going to back up a page. So here the patient's drowsy, and then we see these vertex waves here in the parasagittal regions. And if we go back a page, these are probably sleep spindles here. Not the best formed, but those are spindles, and we can see they're in the frontocentral regions, about 11 to 14 hertz. They're symmetric, and that is indicative of stage N2 sleep, as has been indicated here. And here's some more spindles here. And what about this? Is this a spindle? It's not. And why? Look at the location. This is not just in the parasagittal head regions, and it's also posterior. This is just awake background. This is a common mistake. People will think these are spindles, but that's just the patient waking up and then getting drowsy. So some eye movement here. And again, this patient's just drowsy, kind of going back and forth between drowsy and wakefulness. Some more eye movements, waking up here. This is muscle artifact here. And again, some muscle, looks like chewing. The patient is chewing here or clenching the teeth. And this is more drowsiness. This is a nice picture of drowsiness. The background is very attenuated, just looks like, lower amplitude here. We're not seeing that nice gradient. We don't see the posterior dominant rhythm. And now we would keep an eye out for vertex waves. That would be the next thing you'd expect to see if the patient were getting more drowsy. But no, instead of getting more drowsy, the patient is waking up here. And here we see something interesting here. This kind of activity. This is an electrode popping off. See this? If I turn down the sensitivity, we can see this mirror image pattern here. This is the electrode popping, and it's C3 that's popping. It's the electrode that's in common between these two chains. So that's popping there. And the tech just needs to push on that electrode to just make it stick back down. It looks like T5 might also be popping off there. It's important to recognize artifacts in EEG because, again, they can be mistaken for epileptiform. One of the hardest things about our job is just being able to figure out what's normal and what's abnormal. So here the patient is, again, asleep. These may be spindles here, and these are what's called posts or positive occipital sharp transients. We can see these during drowsiness and during sleep. They're called positive because now in EEG convention, positive means a downward deflection, and this is upward, but it's upward on a bipolar montage. If we switch it to a referential montage, these would actually be positive or pointing down. So if we mark this and change it to a referential, let's see if we have a nice referential montage here. This is referential. I'm going to turn down the gain on this, whatever this is, that's really high amplitude. So I marked this, and if we look in the occipital leads here, we can see these are positive. They're pointing down. Positive occipital sharp transients. So again, this is a normal finding. I always think that these sort of look like shark fins, the way that the morphology, and these can get mistaken for epileptiform because they can look very sharp and they often appear in runs and trains. But epileptiform activity in the occipital head regions, it's not positive, it's negative, so it points downward, not upward. And these have a very characteristic appearance, the posts. So the experienced electroencephalographer would not mistake those for epileptiform activity. Okay, now as we continue here, we see the photic stimulation, and we can see the light flashing. The patient looks like the patient is getting drowsy here, so I'm not really seeing too much response initially, but it does look like there's some driving here. We can see the flash and then the background driving at the same frequency again here. And this looks like the patient is getting drowsy with some vertex waves, possibly even some spindle activity here. And these are actually runs of posts here. See this? They have almost a triphasic appearance to them. And see how they appear in runs here? They look like shark fins in runs. And they can be quite high amplitude. We'll see them in drowsiness, but they will persist through to deeper sleep stages. And here's some more sleep spindles right here. Spindles, so nice stage N2 sleep, more posts here. And if we go ahead and change the montage to referential, we can look at these and see that in the occipital head regions, so in O1 and O2, we can see these are positive. They're going downward deflections. These are all posts. So here the eyes are open, patient's awake again, drowsy here, very sleepy. This patient is wanting to go back to sleep, and that's it. So this is this is a normal EEG in the awake, drowsy, and sleep state. So we didn't see any epileptiform activity, and we did see a few interesting findings. We saw a lot of posts, and we also saw the background that looked a little spikier than usual.